Please stand by. We are about to begin. Good day and welcome to the ASTO Virtual Series Session 3 Primary Prevention Conference Call. Today's conference is being recorded. At this time, I would like to turn the conference over to Elizabeth Romero from ASTO. Please go ahead.
Thank you and welcome to everybody. Thank you for joining us on the Moving Upstream to Prevent Substance Misuse and Addictions, Primary Prevention in Action. I'm going to turn it over to Dr. Jay Butler, our Chief Medical Officer and Director from the Alaska Department of Health and Social Services, as well as ASTO's President. Dr. Butler?
Thank you, Elizabeth, and welcome everybody. This is our third webinar, building on the President's Challenge. As you may or may not be aware, the President's Challenge is focused on public health approaches to prevention of substance misuse and addiction. And we recognize that addressing substance misuse is something that has become high on all of our radar screens in light of the opioid crisis, and there are no easy solutions. Just the other day I ran into an old colleague who said, so what is the solution to the opioid crisis? And I couldn't resist responding, well, the first solution is recognizing there is no the solution, that it's going to require a multi-tiered response. And that is something that we've used the President's Challenge to communicate the concept of the comprehensive approach we need to addressing the opioid crisis as well as the long-standing challenges of substance misuse and addiction in public health. The slide that hopefully you can see on the Adobe Connect shows the three tiers of the response. And earlier webinars have addressed the top layer, which I've labeled as tertiary prevention, which really looks at how do we intervene to prevent the life-threatening adverse outcomes associated with substance misuse and addiction. The second tier is focused on diagnostics and screening as well as treatment to addiction and substance misuse disorders. And we focused on some of the stigma that is associated with addiction and removing stigma to remove one of the barriers to treatment, and also increasing understanding of addiction as a chronic condition affecting the brain, also increasing availability of treatment options. Today we move into some of the foundational aspects of the challenge as it relates to primary prevention, environmental controls, and addressing social determinants to reduce the need to self-medicate, to control access to addictive substances, and to promote protective factors. We have a great lineup of speakers today that will help us dig into this a little further. I'm very pleased to introduce Brigid McCaw. Brigid is Medical Director of the Family Violence Prevention Program for Kaiser Permanente, Northern California, where she oversees the implementation of comprehensive coordinated approaches to improving screening, identification, and services for family violence. She guides the national Kaiser Permanente efforts in this area, impacting over 12 million covered lives. As you may recall, if you attended the ASTO annual meeting last year or some of the earlier webinars, we've talked about how the challenge of substance misuse and addiction is both a cause and effect in a web of cause and effect factors that relate to interpersonal violence and increased adverse childhood experiences. Dr. McCaw's leadership, research, and publications focus on developing a health system's response to family violence, adverse childhood experiences, and trauma-informed care. She received her doctorate in medicine from the University of California, San Francisco, and master's in science and public health from the University of California, Berkeley, and completed an internal medicine residency at the University of California, Davis. She's a fellow in my favorite physicians organization, the American College of Physicians, and is past president of the National Health Collaborative on Violence and Abuse, and is a member of the National Academy of Medicine Forum on Global Violence Prevention. She lives in the Bay Area with her husband and family. Brigid, welcome to the webinar, and we look forward to hearing what what are your insights within the perspective of Kaiser Permanente?
Well, thank you very much, Dr. Butler. And I know that you'd asked me to share parts of a presentation that I gave recently at the ASTO annual conference about adverse childhood experiences, also known as ACEs, because of their relevance to primary prevention of substance misuse. And I'm assuming that most of the folks on our call here are familiar with the CDC Kaiser Permanente ACEs studies. And just as a reminder, this groundbreaking study collected data on the prevalence of childhood exposure to various forms of child maltreatment and household dysfunction, such as domestic violence and parental loss, mental illness, and substance abuse. And the study demonstrated the long-term physical and mental health impact of these exposures and their role as a root cause of many of our most difficult and intractable public health problems, including addiction. I'd say many consider this the most important public health study of our time. So currently, we have 39 states collecting prevalence data on ACEs, and we know that approximately 15% of the adult population have been exposed to 4 or more of the 10 adverse childhood experiences that were studied in the initial study. And the study findings, which have been replicated across many populations, show a graded dose-response relationship such that the number of adverse childhood experiences, as those increase, so does the likelihood of using alcohol or other drugs and starting to use them at an earlier age. And people with ACE scores of 5 or more are more likely to misuse prescription pain medication and 7 to 10 times more likely to use illegal drugs and report addiction. So our challenge then is, how do we move from the ACEs data into taking action to improve our treatments for addiction and target our substance abuse prevention efforts more effectively? So the next slide shows a statement from Dr. Daniel Sumrock, who's the director of the Center for Addiction Sciences at the University of Tennessee College of Medicine. And he says, it's not the drugs, it's the ACEs. So why is this statement really important? Because our treatment is going to be less effective if we ignore the fact that for many people, using substances, and that includes food, tobacco, as well as alcohol and other drugs, can be attempts to deal with the chronic stress of adverse childhood experiences. And Dr. Sumrock and others argue that this needs to be addressed as a component of addiction treatment. But perhaps even more importantly, if we ignore the role of ACEs as root causes, we will miss some of the key primary prevention opportunities to address one of the important drivers of substance misuse. Next slide shows that we now know much more beyond the epidemiology about how exposure to ACEs and toxic stress change the brain and body and lead to medical and mental health problems and physiologically increase the risk for substance misuse and relapse. So for example, the neurologic impact, especially on the developing brain, can impair the areas of the brain that govern self-regulation, impulse control, and executive function. These all play key roles in addiction. The short and long-term effect on the body of chronic activation of the stress system can cause biochemical changes in the chemical receptors that affect craving and tolerance. And in addition, we're learning much more about the epigenetic changes that play a role in how ACEs are passed across generations. But really importantly, we also know much more about the plasticity of neural networks, of resilience, and the ability to learn new skills and responses even as adults. So healing is possible, and biology is on our side. And I think this piece of the science is really important to include in our approach to both substance misuse treatment, but also prevention. On the next slide, I want to talk a little bit about how a large integrated healthcare delivery system like Kaiser Permanente is acting on the science and bringing these learnings into practice to identify high impact opportunities for addressing ACEs. And here is a picture that I find helpful, and I'm sharing this with you because regardless of where you work, whether you're at the state health policy level, the director of an agency, ensuring frontline services, or a substance abuse expert, I think we all need to be thinking strategically about how to prioritize high-value opportunities. So on the left side is the focus on reducing the impact of current ACEs. This is primarily going to be for children and families. And first and foremost is identifying and addressing child abuse and neglect. This is really where you keep the first domino in ACEs from falling. Second are adults with intimate partner violence, substance abuse, and depression, especially those who are caring for children. And when you do this in prenatal care, you get an immediate 2 for the price of 1, or what I like to call 2-generation impact. These things are really must-do for healthcare settings. And by the way, when you mitigate these conditions, which together account for 8 of the 10 ACEs, this is primary prevention for substance misuse in the next generation. Now on the right side, for adults with past exposure to ACEs, there are areas where ACE-informed interventions are likely to be much more effective than usual care. And these are substance misuse, including tobacco and morbid obesity, where what looks like the clinical problem may also represent a patient's attempted solution to ACEs. And ignoring that may be one of the reasons that treatment gains are not sustained. The other conditions listed, chronic pain, complex chronic conditions, intimate partner violence, HIV/AIDS, have a high association with ACE exposure, often complicated by coexisting substance misuse. And these are also high-value opportunities for including attention to ACEs in education and treatment. And as a reminder, again, successful treatment of adults with these conditions often has the ripple effect of being primary prevention for the next generation. Just a couple of words about the primary prevention areas that can happen in every healthcare setting, and that is really making certain that we have family planning services so each pregnancy is desired, and that there are parenting skill classes offered so that every parent has access to tools and information about child rearing. So now what I'd like to do, and on the next slide, is to share an example of putting a high-impact intervention into action. In Northern California over the past 5 years, we've successfully incorporated workflows for routine identification and services in prenatal care for depression, substance abuse, and intimate partner violence. This is really a great example of immediate value that comes from integrating behavioral health into a primary care setting. And it's a winning strategy. These interventions can improve a mother's well-being and obviously infant outcomes. And it has that 2-generation impact, which makes good clinical and economic sense. On the next slide, I want to show you that knowing that ACEs are often an underlying factor for each of those 3 conditions, prenatal depression, IPV, and substance use, and also increase the risk for obstetric problems and preterm delivery, we decided to pilot the feasibility of ACEs screening as part of routine prenatal care. And so we incorporated the ACEs screening tool and the Connor-Davidson Resilience Scale at a routine second trimester visit and put the training and workflow and tools in place to support that. And here's what we learned. It was feasible. It didn't disrupt clinic flow, and it helped clinicians identify women at risk who might not otherwise have been identified. And including the resilience scale along with the ACEs survey was important. It gave clinicians a way to acknowledge the patient's past ACE experience, but shift to the present and emphasize healing and offer skill-building resources with immediate benefit. This is one of the ways that we're making use of the science on resiliency and healing. Patients and clinicians found it clinically valuable. Here's a comment from a patient. This is exactly what I needed. I never knew how to talk to anyone about this. I'm so glad to have had the opportunity. And from a clinician, most of the time the screen is negative, and it's really easy. But when you find that person, you're so glad you did. So if you'll move to the next slide, I'd just like to finish up by emphasizing that interventions in prenatal care and early childhood offer golden opportunities for addressing ACEs, promoting strength and resilience, and breaking intergenerational cycles of ACEs and substance misuse. And they're really good strategic investments in primary prevention of substance abuse. So thank you very much for this opportunity to present on this webinar.
Great. Thank you, Brigid. And you point out that your first slide showing the assessment of ACEs across the country reminds me of one of the specific recommendations that we provided to the state health officials in the President's Challenge, is to seriously look at the assessment of ACEs within their jurisdictions, particularly using the Behavioral Risk Factor Surveillance Survey as a tool for that assessment. So thank you for that overview, and we look forward to having some discussions when we have our question and answer time after the third presentation. So I'd like to move on now and introduce Tracy Dolan, Vermont's Deputy Commissioner for Public Health. Tracy's been working in public health for 18 years, getting her start in British Columbia, working with vulnerable populations and reducing the risk of HIV. She spent 10 years working in international health, primarily in sub-Saharan Africa, with a focus on HIV/AIDS care and prevention and maternal child health, as well as youth reproductive health. For the past 7 years, Tracy has worked with the Vermont Department of Health, where she was hired in 2009 as Director of Planning. In 2011, she was appointed Deputy, and in 2014, she served temporarily as Vermont's Acting Commissioner of Health. She holds a Master's of Science degree in Community Health, and she lives in Jericho, Vermont, and is married with 2 young children. Seems like we have an outdoor theme today of people who live where they can hike, run, and snowboard. So welcome to that fold, Tracy, and welcome to the webinar. We look forward to hearing more about your experience in Vermont.
Thank you. We're just living the dream, Jay. All right, so thank you very much for the introduction. I'd just like to first talk a little bit about the mission of the Department of Health, probably similar to other missions in other departments of health across the country. That's protecting and promoting the best health for all Vermonters. And briefly on our organizational structure. So Vermont is somewhat unique in that we have the alcohol and drug abuse programs housed within our Department of Health. And so you can see here we have a commissioner, we have a couple of deputy commissioners, I'm one of them, and we have a deputy commissioner uniquely positioned above alcohol and drug abuse programs. And that's probably about half of our budget, and so we manage a lot of the treatment through preferred treatment providers. But we do have a broad mandate around prevention, intervention, treatment, and recovery. Also within our health department are all the usual departmental health department types of areas: environmental health, chronic disease, maternal child health, etc. And so the mission of the Division of Alcohol and Drug Abuse Programs is to prevent and eliminate the problems caused by alcohol and drug misuse. I think the positioning of alcohol and drug abuse programs within our Department of Health has been helpful in moving Vermont fairly quickly toward a progressive public health stance to this issue. And so a few years ago, our governor took a really leading step in the nation by proclaiming the issue of alcohol and drug abuse, and particularly the opioid epidemic, as a public health issue. And that has been really helpful as we work with partners here in Vermont in terms of the prevention piece as well and looking upstream. So the first column here under our State Substance Abuse Services looks at the Department of Health, our ADAP division. And in general, you can see what I talked about here: prevention, intervention, treatment, and recovery. And we oversee the preferred provider network. But we also have our Medicaid, which is called DEVA here, the Department of Vermont Health Access. And Medicaid, of course, plays a significant role in care coordination, also in treatment. It does our utilization reviews. And then finally, the other column is the other state partners. So, of course, alcohol and drug abuse programs are not just the arena of public health or just Medicaid. but we also have our Department of Children and Families involved in screening. We have our Department of Corrections, which is also housed under Health and Human Services. They also have programs, and we have mental health, Agency of Education, et cetera, as partners. So our public health approach for substance use focuses on population and individual health, so we do look at the continuum. We use data to understand consumption and consequence patterns, and we understand the nature and impact of the problem to set priorities for policy, access, and infrastructure. This seems straightforward for those of us in public health, but because the world of substance abuse doesn't necessarily always brush up against the world of public health, when we talk to partners, we often have to start at a basic level to talk about how we approach this as a public health issue. So today I wanted to talk about our prevention efforts. In particular, there's one significant grant I wanted to talk about, and this is the Regional Prevention Partnerships. This was awarded through SAMHSA a couple of years ago. It's a 5-year program. It was a continuation of an existing SAMHSA program called Partnership for Success, and it really looks at a regional approach to substance abuse prevention. The SAMHSA has really tried to encourage localized, tailored responses. So in Vermont, we have a centralized system, and so our offices of local health are part of the Department of Health, and we have 12 local health offices. In terms of the alcohol and drug abuse prevention programs, in each district office, we have something called a prevention consultant, which is someone whose job is uniquely focused on substance abuse prevention. And so in each local office, we have the prevention consultant who provides local technical assistance and networking and facilitation in a given community, really meant to provide some leadership around substance abuse prevention. And then, of course, we also have the district director, so the director of our local health offices, who also is the face of public health and the face of the higher level decision making around substance abuse, particularly the prevention side. And so when we get grants that go out to communities, they either go out through these districts or they go out in conjunction with these district teams. Just briefly looking at the strategic prevention framework, again, similar to a framework you would use for most public health issues. There's assessment, capacity planning, implementation, and evaluation. And then our prevention model, which is really a socio-ecological model, looking all the way from individual through relationships, organizations, community, and policies and systems. So like our other public health initiatives, when we look at substance misuse and in the area of prevention, we try to ensure that we have interventions in place and programs in place at all of these levels. And while I won't talk about ACEs in my presentation, our last speaker spoke well to it, I would say that our nurse home visiting programs are really core, I believe, to what I think of as substance abuse prevention. The findings are very strong, and we have a pretty substantial nurse home visiting program. I won't speak to that specifically today, but I do think that that is a key foundational piece to substance abuse prevention. So the goals of the Regional Prevention Partnership, that big SAMHSA grant that I was just mentioning, our goals were very specific. They were reducing underage drinking and binge drinking, and these are specific to Vermont's data and where we have issues. Reducing marijuana use among young people, reducing prescription drug misuse among young people, and increasing our regional prevention infrastructure and capacity. In Vermont, I presume like in other states, we have been slow and underfunded in the prevention world for substance abuse and misuse. Especially with the opioid epidemic exploding, there's been a very strong focus on treatment, which is important, and it's certainly a secondary prevention, but the primary prevention piece has been garnering less attention. And so as a public health agency, it's really important for us to continually be at the table, to continually bring the focus back to prevention as well, and ensure that in the same breath, when we talk about treatment, recovery, and intervention, we also talk about prevention. I'm going to skip through this. This just talks a little bit about the cohorts of the groups that received our Regional Prevention Partnership funding through SAMHSA. So we are throughout Vermont. It's just a brief map showing where our partners are. Here, I wanted to just put this slide up that looks at our grantees, just so you get a sense of the kind of grantees that we look for. So we have a youth services slant here, but we also have a medical center. We also have a regional planning commission. So we really try to look at a variety of types of organizations to partner with around prevention. Learning services, a United Way, a collaborative of prevention and health groups. And so the focus on the regional prevention infrastructure is one part of this. We're really trying to build up infrastructure so that this is ongoing. And so they use the strategic prevention framework. They coordinate across the region. They coordinate prevention media messaging. So we do run significant campaigns out of our central office here. And we have some very progressive campaigns. We work with Rescue Social Change, which is a great media organization. But we also really encourage some tailored work at the district level as well. We also do an assessment, and so our state epidemiological outcomes work group produced these partnerships, these profiles, and so each district has their own profile so they can understand what their demographics are and what their unique factors are. Some of the planning and strategy menus, so when we provide these grants, there are some required elements and then there are some optional elements. In general, the required elements include policy work. So we're looking for organizations to work on changing policies around restricting alcohol outlet density and hours of operation, for example. Social host liability enhancements, language in town plans that support this kind of work, enhancing local underage drinking, DUI or other drug law enforcement efforts, sobriety checkpoints. In the area of prescription drugs, a required element is education and outreach to community on proper storage and safe disposal, promoting prescription drug take-back events. But we have a lot of optional pieces too, which include family programming, courses like Family Matters, Guiding Good Choices, Nurturing Parenting Program. These are all evidence-based programs that we promote and offer and provide technical assistance on. So just a few highlights from our most recent implementation. We've been doing a lot of integrating of substance abuse prevention into healthy communities frameworks and municipal planning. So we've got municipalities now that really take this as their own issue, and that's been really wonderful. And they design resources, including a healthy community design resource for their own planners. We've been doing universal screening at local colleges and universities, piloting a program with universal screening with a community college campus, expanding prescription drug drop boxes, and we've actually been successful in saturating most local law enforcement agencies with a drop box. So just speaking to a few other prevention efforts, we've been really trying to promote that prevention infrastructure. So we're giving grants to 4 existing high-functioning coalitions to continue their outcomes toward reducing underage drinking, high-risk drinking, and marijuana use. We've been working with the schools. We just did an evaluation. We weren't able to get enough funding to support all schools in the area of substance abuse and substance misuse, but we were able to provide funding to about 1/3 of our school districts in the last couple of years, the 3rd neediest. And when we then controlled and looked at an evaluation, we found that the areas that had this support versus the areas that did not have this support made significant gains in some of the key measures that we look at on the YRBS. So that's been really exciting to see. So some of the goals here are reducing past month use of alcohol, marijuana, or illicit substances among adolescents, reducing binge drinking, and increasing the capacity of schools to coordinate substance abuse prevention and early intervention. I'm going to close on this piece. We this past year, the governor put out an executive order to develop an opioid coordination council. So the attention has been great. So it's a high-level council, and the governor has pulled together public safety, schools, public health, a variety of key leaders, business leaders, to come together and make more recommendations around what we can do around the opioid epidemic. So that kind of attention is great. Some challenges in that. Because it's so focused on opioids, we have found that there's been a little bit of a challenge on keeping the attention on what we know continues to be a significant problem, which is, of course, alcohol misuse. And so that has been a challenge, and trying to bring that back under the spotlight has been important. But also the prevention message. It does get tough when you have a lot of law enforcement in the room to continue to come back to the prevention message. Like other states, we've had challenges where our public safety and the police want to get into the prescription monitoring system in order to do their police work, which is, of course, not the goal of the public health goal of those systems. And so it's a really good opportunity because our commissioner sits on this Opioid Coordination Council. It's a really good opportunity for Dr. Levine to continually bring people back to the broader picture, to understand that it's comprehensive. The idea of one solution, like Jay Butler mentioned at the beginning, continues to come up even in this Opioid Coordination Council. Even though people hear the message, the default when it's stressful is to go back to the idea that there's one solution. So right now, the hot topic is physicians are overprescribing, which is true, they do, but it's not the sole issue. And when we talk to treatment providers who work with young people, they tell us that while, yes, there are a chunk of young people who have come in because they were abusing prescription drugs, it's rare that that's the only issue that those people were experiencing. And so I've actually reached out to CDC because CDC has some statistics around this that I find a little bit misleading, where they describe the move from prescription drugs to heroin addiction as being primarily fueled by the misuse of prescription drugs. And while that's the most recent event, according to our treatment providers, it's rare that that really was the only issue leading up to this. There were often other substances or other issues leading up to that connection. And so really getting that message out there that there are just many paths. Yes, we have to work with physicians, but we absolutely have to continue working with young people. And we need home visiting in order to disrupt ACEs, all the pieces together. And so we are all on the same coordination council. It's a small state. We talk a lot, but still the cultural differences between how we look at things continues to exist. And so we are continually working on this and hopefully making very good progress. We had the drug czar here. He's acting from the National Drug Enforcement. I forget now the acronym. He was here. He was great, and he actually pointed this out. He was wonderful. He really is trying to promote prevention as part of his role, and so it was really helpful to have him here from the national level to really speak to this issue, that it really is more complex. Even though we put it out there in sound bites what the causes are, it is complex, and we need to continue to grapple with the complexity. So thank you very much.
Very good. Thank you, Tracy. I really appreciate that very pragmatic and real-world viewpoint for those of us that are in state health departments. And I also really appreciate the really comprehensive approach that the Opioid Council is taking, as well as your point about we really need to not be focusing on single molecules, that there are broader issues, particularly as we talk about primary prevention and how that relates to substance misuse and addiction. So our next speaker is Jared Arnett. Jared comes to us from the Shaping Our Appalachian Region, Incorporated, or SOAR. Jared has got a number of great credentials to be in his role, but probably the strongest is he's a native of Eastern Kentucky. So he has a heart for the people and for the region and the business functions of Eastern Kentucky. He stepped into this role that actually he founded and created in November of 2014. And this was a result of a special initiative launched by Kentucky Governor Steve Beshear and Congressman Hal Rogers, two elected officials who I think we can really admire for taking initiative in addressing the opioid crisis. SOAR's mission is to expand job creation, enhance regional opportunity, innovation, and identify an identity, and improve the quality of life and support all those who work to achieve these goals in Appalachian Kentucky. Prior to his founding post at SOAR, Jared was president and CEO of Southeast Kentucky Chamber of Commerce. He was instrumental in expansion of the organization, both geographically and strategically. Before working at the Chamber, his career included serving as the Director of Finance for Soundhouse Music, General Management Consultant for Eastern Kentucky Small Business Development Center, and at age 26, he started his own consulting firm, Beacon Management Solutions Incorporated. Jared, we know you're speaking to us as someone who has really lived in what sometimes called ground zero of the opioid crisis. We appreciate the work that you've been doing, and we look forward to hearing from you now. Jared, can I turn the stage over to you?
Thank you, Dr. Butler, and it's an honor to be on the call today. It's for me, as you can hear in my bio, coming from more of a business background and economic development background, I enjoy the opportunities to speak about public health and its impact on the work that we do and how we integrate it into the bigger picture of our work. SOAR was started about 4 years ago as a political initiative, bipartisan political initiative by then Governor Steve Beshear and Congressman Hal Rogers. We're an independent 501c3 nonprofit organization, so we're not a government agency per se or quasi-state government. We are independent. It just happens that in our bylaws it reads we are co-chaired, our board is co-chaired by the sitting governor of Kentucky and the sitting congressman of the 5th District. That means now our organization is co-chaired by Governor Matt Bevin and Congressman Hal Rogers. We've continued over the last 2 years under the new administration to move our work forward. You see this first picture here. This was our summit last year. SOAR got started with an annual summit in 2013 after we had in this region a decline in the coal industry, which has been made known nationwide and become somewhat of a hot topic from a political standpoint. But the reality at ground zero was over about 6 years we lost 12,000 jobs. And I had neighbors, we all had friends that were trying to decide what next steps were. And a lot of that was moving out of the region. And in the midst of that, these two leaders got together and said, we've got to do something. We've got to diversify the economy. We've got to make a path forward. They held a summit. Over 1,600 people attended the first summit. And we've continued to have well over 1,000 attend our annual summit here in Pikeville, Kentucky. We just had our most recent one on August 4th, and had over 1,200 people who attended that, talking and showcasing the work of the region. I want to paint just a little bit of the picture of the work, the task at hand, the region that we're working in. We're in the heart of central Appalachia. This is a map from the Appalachian Regional Commission. And these red counties are distressed counties. Those are economically distressed counties based on unemployment rates, per capita market income rate, and poverty rates. So these are the counties in the red are in the bottom 10% of the country economically. And as you can see, we work in all the counties in Kentucky at a baseline level to change the colors of those counties. And that work has been ongoing for way before we started. There have been a lot of organizations and government programs trying to address this. And you see that there's still a lot of work to be done. And just to map out the correlation with the poverty that may be in our area and the economic distressed area is obviously a correlation with life expectancy, health outcomes, and we we do have some of the some pretty bad outcomes on cancer rates, on obesity, on substance abuse across the board. And what we found in our work as a collective impact organization, that none of those outcomes can be addressed, as has been said over and over, from a here's the solution perspective. So I'll get to talk about our work in just a minute. This zooms out and does the entire country based on the Appalachian Regional Commission's grading of each county, and you can kind of see even at a national level, this is, as we say, ground zero for some of the work that's going on in our line of work. We believed at the beginning that the most important thing was change, and it had to be driven by innovation. And we've done that through a collective impact model. I want to kind of just show this picture. This is from one of our board meetings. So if you can imagine your upcoming board meeting, it's co-chaired by the governor and congressman. We typically have as many as 300 people who attend a quarterly board meeting talking about the work that we do. And this is here, the governor and congressman, and with a team that created an app, and they won an award. That you can see the crowd that's there. Many of you have probably heard the collective impact identification and may work in it. And but this is the definition we essentially use. Collective impact is a framework to tackle deeply entrenched and complex social problems. We realize that none of the outcomes that are happening in this region no one person can be assigned responsibility for the negative health outcomes. Not the public health agencies, not the communities. This is really, it takes a collective ownership to say we're all a part of this, and we've got to do our part to make a difference. These are the 5 requirements for collective impact. I'll share real quickly ours, how we line up with these 5 requirements. At the beginning summit 4 years ago, we took impact input over the first year from over 3,000 people and put together, we just formalized it last year, our blueprint for a 21st century Appalachia. This is what's known as the common agenda. This is what over 1,000 partners have come together and said, these are our goals. There's 7 goals in that blueprint. This is what we're going to work toward as a region. And then obviously we are working now to identify the specific metrics on those 7 goals and share in the ownership of those results and outcomes. We have many mutually reinforcing activities in the way that we're structured. We have roundtables. We have SOAR Advisory Council. We host our annual summit, and this continually brings people together, and it shows those working in workforce and those working in public health how their work interrelates and connects. We built a social network called SOAR.network that allows individuals to get on and share their project or program and how it aligns and is moving the overall blueprint forward. We want every organization to understand that they're not just working in their silo, but they're working as part of a bigger movement, a bigger picture. And every collective impact movement needs a backbone organization, and that's us. We're the ones calling the meetings, holding people accountable, continue to be the champion and casting the vision and continually bringing people together. These are the 7 areas that we work in. Our blueprint, 7 goals. You can see the 4th one there is healthy communities. But we work in industrial development, broadband infrastructure, small business, 21st century workforce, regional tourism, regional food systems. And all of these work together. I say we do this, we really just manage it. We really don't do any specific program on any of these. We're a small organization with 4 people, but we bring people together who are doing a lot of this work and give them direction and guidance. I'm going to skip this as we're getting kind of late on time, but this is as an organization, these are our top 3. These are the things we do each year. Drive action aligned with the regional blueprint. We're the champion promoting and inspiring Appalachia, Kentucky, and we're working to grow the team of partners in number and capacity, leadership capacity, resource capacity of those partners. These are just a few pictures of different events and programs we've done as it relates to substance abuse. We've been very thankful and appreciative that over 2 years ago, CDC assigned a public health advisor to our office and also a public health associate, the PHAP. That those two have worked out of our office and led many of our initiatives that relates to public health. Dr. Bill Hacker has been our chair of our action team as it relates to public health and organizing volunteers. We've had several different events. We had a hepatitis C roundtable where we brought people together to discuss the impact in our region. We had federal officials, state officials, local health departments, local elected officials come together to talk about the impact and the potential outbreak of hepatitis C and HIV as it relates to needle usage within our region and harm reduction programs, and we've seen an expansion of harm reduction programs after that in many of the counties that we serve. In partnership with MIT, we held a hackathon where we brought not just public health officials together, but also healthcare and entrepreneurs and engineers and focused on the health in Appalachia. And we live streamed several of that and had high school students in different schools delivering solutions. And we've worked, I think in the biggest part of our story for me is just the number of organizations that we've been able to work with that have showed up and partnered with us. This is just, I've got 3 screens here that show the partners. And this is just within our area focus on health. And so we have this same list and logos for all 7 areas that we work in that have unified under the SOAR umbrella, that are bought into the blueprint, are committed to moving the region forward, and we're beginning to track metrics and outcomes. So we are just excited to move forward. Our next event that Jenna Meyer, our CDC Public Health Advisor, and our team is putting together is in partnership with the Kentucky College of Osteopathic Medicine here in Pikeville. It's a 4-hour provider education on substance use disorder to medical students and different rural providers within the region. So we're going to have state and local subject matter experts that will be presenting information on best practice guidelines, the Kentucky law related to the prescribing of opioids for acute pain, and access to the tools and resources needed to help prevent and manage substance abuse in rural practice. Looking at over 300 medical students on site at that event, and also rural providers, and we're going to be streaming it and having remote sites as well. I think in closing, the most important thing I think for states and communities to recognize is that the public health department can be responsible for adequate programming, but the true outcomes in a community are owned by the entire community, and it takes more than just one organization, especially in an economic distressed area like we're in, and the social determinants of health are so strong. One without the other, job creation without public health, or public health without job creation, we end up spinning our wheels and never reaching our goal. I think we've been able to bring respect to both sides and bring them to the same table and identify common goals and begin to get everybody working together. I'm not saying everybody in Eastern Kentucky singing Kumbaya, but we have made tremendous progress over the last 4 years. Thank you.
All right. Thank you, Jared. That's really, I have to say, inspirational in terms of what you've done in Kentucky. It really highlights one of the areas of focus in the President's Challenge is developing those partnerships, recognizing that a multi-sectoral approach, achieving the goals of collective impact, are the way we're going to make a difference, because we've increasingly been recognizing that it's not just a criminal justice issue, it's not just a health issue, it's not just an education issue, it's all of these issues. And the responsibility can't just fall to government. It can't just fall to the not-for-profit sector. It can't just fall to the health care system. It can't just fall to business, but really all of us need to step up and be responsible in the response. So thank you. And I think I want to thank all three speakers because it's been a great, movement through the perspectives of the healthcare system, public health systems, and then finally a very broad community-wide systems approach, how we move forward with some of these primary prevention tools, which are not, I'll be blunt, are not as easy as putting together naloxone kits, which is a wonderful part of the response. It's life-saving, but as I like to say, it's just a tourniquet and doesn't begin to address some of the long-standing issues that have led to where we are today. So at this point, I'd like to stop. I'd like to ask the operator to provide us any brief instructions we need in terms of how to pose questions, and I'd like to open the floor for questions for our presenters.
Thank you. And if you would like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Again, that is star 1 if you would like to ask a question.
And maybe as we wait for a question, I'll do moderator's prerogative and jump in with one. This is for Tracy Dolan. As you described some of the work through the Coordination Council in Vermont, as well as work by the Department of Health, I noticed on your slide, looked like Department of Corrections screening and therapeutic communities. People may not necessarily think of those measures as prevention, but if you use the conceptual framework that I presented early in the presentation, I want to use that as a chance to say there are not sharp red lines between the tiers of response, because oftentimes treatment also has a role in primary prevention, and in particular as it relates to adverse childhood experiences. An example would be the incarcerated parent who goes into treatment and comes out of prison, and rather than returning to a cycle of recidivism, is actually returning to a life of living in recovery. That parent is going to have a child with overall lower ACEs scores, at lower risk of themselves experiencing substance use disorder. Tracy, do you want to comment on, or can you comment on how the Department of Health has worked with the Department of Corrections in this area?
Yes, and actually it's interesting. So the Department of Corrections is part of the Agency of Human Services, so that is really helpful from the get-go, because there is a human services perspective in corrections. And corrections certainly sees plenty of people coming into the system as a result of addiction, and sees plenty of people leaving the system and then getting back into addiction, which is, of course, then related to recidivism. So when we work with any partner, we try to frame it around that partner's objectives. Not that the Department of Corrections doesn't care if people are addicts, but they care more about recidivism. So we try to frame it around recidivism. So we've worked with the Department of Corrections and other partners to beef up screening, to beef up kind of an addiction 101 with key staff. We've had some challenges on the quality because we have not been as involved in some of the work that happens in the Correction Center. So now we are working more closely with them on the quality of what's happening in the center, and then particularly trying to get people leaving corrections going right into a recovery network. So we do have a network of recovery centers around the state. They're pretty basic, but we do have a particular program called the Rocking Horse Program, which is unique to women leaving the correction system, and so we also try to promote that model. But it is helpful being within human services. But even within that, there is some work to ensure that the quality is such that that people have the right outcomes.
All right. Great. Thank you, Tracy. Operator, do we have other questions? Oh, go ahead. Please.
Jay, there are a couple questions in the chat box. I think this is for the SOAR team. Do you partner with anyone in Tennessee? Jared?
Yeah, we know several partners in Tennessee, and working with the Appalachian Regional Commission, which works across about 13 states across the Appalachian Mountains. We've been able to develop a pretty strong network across all the states, and we do have some partners from there. Maybe not specifically in the public health area focus, but we're open to working with anybody and everybody.
Great, thank you. And there were two questions for Brigid, one related to other national insurance or other insurance companies or payers that may be addressing ACEs, and then I believe Joanne Clivens also asked what interventions are offered to patients with ACEs and if you've done any trials.
Well, thank you. So, when we think about other healthcare delivery systems, so, Kaiser Permanente is a combination of the insurance company and the medical group and an integrated delivery system where we take care of patients over their lives and have many generations we care for. In those settings where there's an incentive for prevention, I think they are the ones that are most likely to be doing things around ACEs and primary prevention of substance misuse. And Jay perhaps can talk about South Central Foundation in Alaska, which is actually a healthcare system which is looking very broadly at social and behavioral health determinants, and I think has, maybe without necessarily calling out the ACEs specifically, really attends to these behavioral and social issues that are adverse childhood experiences. There are some other healthcare delivery systems, the Brigham and Women's in Boston come to mind, Gunderson, that are, I think, really looking at how do you do this and how do you bring it into everyday care in the way that many of us have been successful with intimate partner violence. To Joanne's question, of course, Joanne, you've done some of the best evidence-based work and evaluation in intimate partner violence. I think what we're learning for ACEs is that patients have very different kinds of goals. And for those people who have experiences that may be causing symptoms that are interfering with daily life, some of those people would really like to be able to have counseling and interventions. There are other folks where mindfulness, where other strategies seem to be more about what fits in their life. And so one of the things that we did in the prenatal ACEs was really come up with a resilience package so that people could look at what they wanted to do, whether it was classes or videos or apps or books or therapy if that was something they wanted. We are not currently doing randomized clinical trials to evaluate what we're doing in terms of intervention for ACEs. Our evaluation has been focused on the feasibility and patient acceptability of ACE screening, and I'd be happy to talk with you more offline on that.
Great. I'll turn it back to you, Jay.
All right. Well, thank you very much. We are up at 3 o'clock Eastern Time, 11 here in Alaska. So our hour is up, and our pledge is always to end on time as well as start on time. So I want to close by thanking everyone who joined us today. Thank you to our speakers. Very broad topic. I felt like we barely scratched the surface, and I look forward to the upcoming time as we continue to move the agenda on how do we use public health approaches to prevent the onset of substance misuse and addiction. And I think we've heard 3 excellent presentations on how we do that in different sectors, and with the bottom line of it's all sectors working together. So with that, we'll adjourn us, and thank you for participating. Everyone have a good day.
Thank you.
And this concludes today's call. Thank you for your participation. You may now disconnect.